Thanks, Ed. I'll introduce myself. I'm Professor Jane Falkingham, and I'm the principal investigator of the team based at Southampton University, working on the Care Life Cycle project. I'm a professor of demography, so it's quite handy to come after Ed, who's talked about modelling for one of the key demographic challenges that we face in the UK today, which is changing migration patterns. But the other key demographic change which is going to face all of us is living in an ageing society and the health and social care needs of that ageing society. And why I'm interested in that is because it's going to affect me. I'm one of the baby boomers. In fact, I was born right at the peak of the second baby born in 1963. We've got two baby booms in the UK. The first one were born in 1947, 48. What happens when soldiers come back from war? Well, we kind of know. They have families, and in fact the rise in the birth rate in 1947 was sufficient for an extra classroom in every school in the UK. So if you're from that generation, you should be well used to prefabs in the playgrounds. So we have an ageing population, and the group at Southampton have been developing a suite of models, really looking at how we might better address the health and social care needs of an ageing society. And as with the other teams in the other universities, it's brought together a wide group of people that hadn't previously worked together. And I think that's one of the most exciting parts of this programme of work. So the Care Life Cycle team at Southampton is comprised of people from the Centre for Research on Ageing, led by Professor Maria Evandrou, the ESRC funded Centre for Population Change. The Research Council's quite like this. ESRC thinks it's getting good value out of EPSRC and vice versa, and I direct that centre. The Centre for Operational Research Management Science and Information Systems, and tucked around the corner somewhere over there is Professor Sally Brailsford. And then the Institute for Complex System Simulation, directed by Professor Seth Bullock. And we're also collaborating with a whole range of non-academic collaborators, some of whom are here today, so thank you very much for your collaborations. I won't run through them all, but ONS in particular, and also Hampshire County Council and Southampton University Hospital, where you'll be seeing some examples of some of our models that we've developed in collaboration with them in a moment. So, as I've said, our research programme is really focusing on how the UK health and social care system will cope with an ageing population. And in order to think about that, we actually have to think about things at a whole variety of different levels. And we're taking as our conceptual framework something that we've phrased the care life cycle, which means that our individual care needs as we move into later life are determined by our life course. So what we've done in terms of our family behaviours, how we've interacted with the labour market, etc. But it's also about how we've interacted with the health and social care system. Moreover, migration is critically important, not only for changing the composition of the population and the individual care needs of different people from different backgrounds, but is also actually critically important in determining the health and social care workforce. So we've actually been doing models which are looking at interactions again at these different levels. I think we've heard already this morning about the micro and the macro. So we're looking at models which are allowing us to look at interactions between the individual level, the institutional level, and the population level, and linking a whole variety of disciplines together. By bringing these different disciplines together, we've actually also been able to link modelling methodologies. So we've heard already today about agent-based modelling, and we've also been developing models of system dynamics models and also discrete event simulation models. And the final example I'm going to show you just before you go off to lunch, and you'll be able to see it running at lunchtime, is actually a model which is linking these three modelling approaches together, which we think is quite groundbreaking, and we're very excited by it. So I'll be presenting 3 case studies, and I know that I'm between you and your lunch, so I'll try and go through them as quickly as possible. The first model has been developed in collaboration with Hampshire County Council, and is looking at a whole system dynamics model of social care. The second model is this hybrid model, where we've taken a disease-specific case study where we've been looking at age-related macular degeneration, but we're hoping that we can then take this approach that we've developed and actually move on to look at different disease case studies, and in particular we're contemplating getting into Alzheimer's, although I realise that that's a very complex issue to move into. But the third model, and the one that I'm going to start off with because I'm a demographer, is actually our linked lives agent-based modelling of household composition and change. And the reason why I'm starting off with that is partly because as we age, our linked lives and our life course and how it's linked with the lives of other people is critically important. So changing family structures may affect the future provision of social care. And we live in a world that is increasingly complex. So divorce rates have been changing, rates of repartnership have been changing, we see increasingly blended families, and issues are starting to emerge such as, will you be prepared to care for your ex-in-laws? I don't know how many of you would be prepared to do so. But we need to actually start to look at how these changes in family structures are playing out. And it's important not just to look at individuals, but also their linked lives. So consider, for example, Susan Smith. She was born in 1949. She's at 65 this year, and she's just about to retire. But in 2020, sadly, she will have a stroke, and her ability to get around and to live independently will be compromised. And Susan will need care at that point in her life. How is she going to get it? Well, it depends. We know that the family is the most important source of social care. So is she married? Is her husband still alive, and is he still healthy? Perhaps he'll be able to look after her. But are Susan and her husband still together, or did they divorce years earlier? Did they have children? Do those children live close by, or have they moved to the other end of the country, or indeed to another country? Perhaps Susan never had a family of her own, in which case perhaps she's looking towards her siblings and her nephews and nieces who might help her. Decisions that Susan made decades earlier about getting married or starting a family, and indeed decisions her parents made about how many children to have more than half a century earlier, will now affect her prospects for receiving care from someone close by. So the first model that we've been developing is actually a model that we call the linked lives model, where we simulate thousands of lives like Susan's, and we start the model back in 1900 and simulate people being born, leaving home, getting married, or cohabiting, divorcing, and other life events. And because we're keeping track of all the individuals in the model, we know who's related to who, and when someone grows old and needs care, we know which family members are living close by. This means we're able to explore alternative scenarios about the UK's future. And in particular, we're able to start, again, one of the other presenters mentioned the sandbox idea. We're able to start playing around with different parameters that actually we don't know very much about to see what the impact will be. This is just one of the results, and the team will be demonstrating the model in the lunchtime, but this is just one of the models where we've been playing around with the propensity of older people to move in with their adult children and what impact that would have on the social care bill. So just along the bottom is the rate of moving in with your adult children, and along the side is changes in the social care bill. Well, that's the care bill per taxpayer. And basically you can see actually this is a very blunt instrument. It's not going to do very much. So even if we encouraged more older people to live with their adult children, we're not going to get a great change in the social care bill. So perhaps we need to look at other instruments for thinking about that. The second model that we've been developing is the Hampshire care model. And the first model, the linked lives model, looks at individual people and their family links. This model has a different level, and it's taking a population level perspective. However, it has many connections with and interactions with the linked lives model, and we've actually had a lot of sharing across the different model development teams. We're especially keen that our work has a practical impact, And this model is being developed in collaboration with Hampshire Social Services Department. So we're very grateful to them for the number of hours that the team have put into working with us to help us understand the system of social care in Hampshire. So the high-level overview of the model, for those of you who are familiar with system dynamics, it allows us to look at how different parts of the system interact with each other. And one of the benefits is you can actually look at outcomes. If you change one part of the system, it may have unintended consequences in another part of the system. So, and some of those changes may be counterintuitive. So this model allows us to see the big picture. And basically, people arrive in our model when they turn 65. The model then represents the various ways in which they may receive social care. Of course, most older people don't actually need social care at 65. They need it further on. So, of course, we age people through. And they can receive care from family and friends. They can also receive it from the private sector. They can receive it from the statutory sector. They can receive it in terms of a combination of those, or they cannot receive it. And we're also looking at the implications if they don't receive it, what happens at the other side in terms of inpatient stay and inpatient care. And that's another important part of our work, is we're actually linking the social care system to the healthcare system. So you can have savings in one sector which will actually end up with costs in the other side of it. So this is the high-level view. This is the more complicated view, which I don't expect you to be able to see at all, but you start to get an idea of how many different parts there are, and this is why we have to sit down with our colleagues in Hampshire to actually work through all the different flows and the different parts. And one of the innovations, again, is I'm going to focus in on this little bit here, which you can't see, so I'll zoom in, is we've actually introduced a variable, again, called willingness to care, and also resources available to care. Now, we actually know very little about willingness to care and families' willingness to provide care to their adult parents. And so what this allows us to do is to run experiments and to vary the parameter on willingness and resources, because it's hard to quantify in practice. Although as part of our team we do have a PhD student who's doing a qualitative PhD, actually looking at how families are negotiating care, which again I think this is so exciting for me as a quant person to see quantitative social science coming together with qualitative social science in a way that I hadn't previously thought about. So we can vary this willingness parameter between 0, which means there's no family care available, and 1, where families are able to provide 100% of the required care. And as I say, the qualitative study currently underway thinks it's around 0.4. So we are able to run our model for 300 months with a time step of a month, and this is what we get out at different levels of this willingness to care. Now, I don't want you to get hung up by the absolute numbers on this. This is just for Hampshire. So that's looking at the number of people who would need care according to these different variabilities. But I think what's the interesting thing to look at is actually the changes as it goes through. And you can see there's very little change actually in the amount of care that would need to be provided by Hampshire. When we vary the parameter from 1 to 0.8 to 0.6 to 0.4, which is where we think we are. But if willingness to care drops below that, then suddenly there's a step change, and there's actually a tipping point that if families were to change their behaviour, then there is a tipping point where actually we could reach a position where local social services are going to have a sudden increase in the demands that are placed upon them. Now, this is just playing with one parameter, and you've seen how complicated the model is. And Joe Vianney, I think, is somewhere in the audience, who developed this model along with Sally, and he will be demonstrating it at lunchtime and will answer all your questions. The third model, in the remaining 5 minutes, and I actually think this is the most exciting model because it's the most innovative, even though I'm very excited by the linked lives model because I'm a demographer, but actually this is starting to bring together these different modelling approaches. And we've got used as a case study research into an eye condition called age-related macular degeneration. And we're hoping that this model is demonstrating the links between health and social care. And as I've said, it's a pragmatic combination of approaches, combining agent-based system dynamics, discrete event, and micro-simulation. So why did we choose age-related macular degeneration? Well, there are two reasons. One is it's the most common form of sight loss amongst people over 60 in the UK, and there's about 250,000 people diagnosed with it. And you can see, this is a picture of what someone with age-related macular degeneration would see. It basically affects the central vision of the eye and obscures what you're directly looking at. And as people develop age-related macular degeneration, they become less and less able to perform independent acts of daily living and will become more reliant on assistance from social care services. So it's primarily a social care service-related need. However, at the University of Southampton, Professor Andrew Lottery has developed a pioneering new treatment for one particular kind of age-related macular degeneration called wet AMD. And if you undergo treatment, it can actually reverse the process and improve sight. But it involves a series of regular injections into the eye. So if you don't have the regular injections, then the treatment won't work. So understanding how the health system works and how we can improve the healthcare will then have positive impacts on the social care system. So we've been very pleased that Professor Lottery was prepared to work with us, a bunch of social scientists and computer scientists, to help understand how his clinic is working and then perhaps helping to improve the provision of services. So we start off by actually modelling macular degeneration. So we're right down at the level of the eye, and we start modelling how many people are actually going to get macular degeneration. And then we model where they're living. And you can see, again, this is in Hampshire, but they're primarily clustered around the urban centres. And the majority of people in Hampshire who develop age-related macular degeneration will end up using the services of the Southampton University Hospital Trust. So then we model the clinic, and again, this will be running at lunchtime, and you can see people running in and out of the clinic. This is a more kind of classical, I would say, OR type model, where you can actually model the patients coming in and out of the clinic and the waiting times, etc. But if waiting times get too long, people go home and don't have their injection. And so what we've been able to do is to see how the clinic is operating and what changes we could introduce into the clinic that would improve the operation of the clinic. For example, the introduction of a new camera, which reduces the waiting time, is one thing that we've highlighted. The other thing we've highlighted is actually the hospital transport. Very often people don't get to the hospital on time because the hospital transport is failing. But if you miss your injection, then you have worsening AMD, then that increases the need for more care at home. That puts more pressure on the social services, which then creates more pressures on the transport system, and etc. So you can go into a negative loop, and that's what our model has demonstrated. But the model has also demonstrated, just by making small changes to the way in which we do things, can actually lead to significant improvements in the level of service and improvements in the level of social care. So this is a real interaction between the health and social care system. And these are just some examples of some visualizations that the model produces. So just to summarize, at the University of Southampton, we've brought together people from a range of different backgrounds demographers, gerontologists, computer scientists, operational research, complexity scientists, and are developing this suite of models. And the models are now starting to talk to each other. So again, just as Ed said, we don't want to develop a grand model that will allow us to look at health and social care. But actually, as we've gone forward and have been developing these individual models, it's clear that the outputs of one model will inform the inputs to another model. So actually getting the different types of models to talk to each other is very important. And this is just the team, and just so you can spot them now, so you can jump on them at lunchtime. So thank you very much.